Any other tell us the story, Rachel.
All right, so as Sonia did, I'm going to start with a particular story from the Natural Disasters Array. This is a quote from a Haitian physician who practices medicine in North America now, but is originally from Haiti and traveled down to respond to the earthquake about 2 days after it happened. So he has a very interesting perspective, I thought. This is one of the things he said. There was that young girl who had both arms broken, chest crushed, and she wasn't going to make it. She was already in respiratory distress. As I was passing by, she looked at me. I looked at her and she said, "Would you cover me? I don't want the flies to eat me alive." And I did. That was very hard. And I walked back and covered her and talked to her a bit. And I moved on to go and look after those we hope to save. This was a very common message in a lot of the interviews. So the Natural Disasters Array, as from the title you can tell, it's not based in a specific country. We talked for a long time at the beginning about selecting a certain disaster, like Haiti, like Typhoon Haiyan. Partly because of the nature of natural disasters. They're unexpected, sudden, and sometimes within a few months, at least that acute phase, there's recovery for years, but that acute phase is over. And so it was a little bit difficult to find a specific place. There was also stories that were coming up from many different sites that seemed relevant. And so one of the limitations of this case study is that because we weren't able to go to the site, we don't have, unfortunately, patient perspectives, but we do have a variety of international healthcare providers and local healthcare providers. So we had 17 interviews that are included in this case study. There's 10 interviews with international healthcare providers, the one Haitian physician who's kind of in a category of his own, I feel. 3 local healthcare providers, all physicians from Haiti, the Philippines, and Nepal. And then there was 3 interviews from the first set that talked extensively about their natural disaster experience that are sort of going to be included in this case study as well.
The set that was presented by Kevin and Karen.
Yes, yeah. We've been referring to it as the first set, I guess. And here's a bit of a breakdown of the professional background of these people. Physicians were strongly represented. We had anesthetists, surgeons, palliative care physicians, and just general practitioners, 2 psychosocial workers, so like a MSW, a social worker, and a psychologist, some advanced practice nurses, and general practice nurses. These are some of the different natural disasters that were discussed in the interviews. I feel like we had a pretty good variety, from tsunamis, earthquakes. The earthquake in Haiti came up a lot, even for people that hadn't actually gone there. It was taken as an example of, I think it's a bit notorious, and so there was a lot of examples pulled from that. And so one unique case was stories of seasonal famine that came up often from Chad and also the Central African Republic. People who worked in those countries, and we debated also for a while about, how do you define a natural disaster? There is always sort of economic, structural violence components to why these countries in particular require an international response. And so I feel like famine is very much hard to define in that way, but there is sort of the natural environment causing more difficulty for people. And so we did talk to some people that had worked in Chad during seasonal famine. Yeah, I think that's it there. So these for the interviews, at this point we only have the 3 from local healthcare providers. I'm continuing to try to recruit a couple of more, ideally. It actually has come up specifically from Haiti that a person who's been helping me try to recruit people has said a lot of the people here have really negative experiences with research, and there's resistance to participating. So it just kind of speaks to our conversation yesterday, but they're quite resistant to participating in this type of research. So, but we're still working. I have a couple of leads that we're following up on. So we're still in the very early stages, but these are some themes that are coming out so far. First of all, this issue of the shock and trauma of a natural disaster. You have a sudden event that is unexpected usually. There's often a massive loss of life in that first day or so. And a lot of times people are separated from family and they may not even know where their family is or what happened. The Haitian physician talked about people to this day, there's a lot of families that still don't really know what happened to their family member. And also, it was also talked about that one person referred to the community as being punch drunk, that they're in shock, and so all of their typical ways of caring for each other and supporting each other and providing care for dying people in their community, they kind of lose that ability to a certain degree. And so part of the role of international responders is she described it as being a flashlight in the dark and kind of helping people remember what they normally would do for these people. And that's part of the role. Related to that, the importance of psychosocial care, several people talked about how local healthcare providers that are caring for patients in these hospitals or in their community after disaster are often experience intense trauma themselves, and so they are trying to care for their country people, and they may have lost their entire family or lost, especially in Haiti, that was a big factor. And not being able to, like, witnessing suffering and not being able to do anything about it, or not having adequate pain management for people that are dying, or being forced to make triage decisions that are really problematic for people, it contributes to their own trauma around the disaster. And then just the importance of psychosocial care for dying patients was really emphasized about being with people, and that it came out a lot in the interviews. Around this issue of the centrality of local providers, many people, especially the international healthcare providers, talked about how really the international aid response is, she described as, we're the last responders, we're not the first responders. Because in that first couple of days, there's basically no international help, and people are left to sort it out on their own, and the majority of deaths happen in that first 24 hours or so, and so we really need to support local people to prepare for these kinds of disasters, since they will likely be the ones to respond. Around infrastructure damage, this came up quite a bit, that you have destruction of roads, destruction of hospitals, and so space, so having beds to put people in to provide care is an issue. And also, a lot of people have difficulty accessing hospitals or places where they can receive care. And I know this was talked about, I think, during that initial talk that Carrie and Kevin gave, that the people that have palliative care needs are often invisible during a natural disaster, because they may not see their needs as critical as people that are injured, and they often also have mobility issues that prevent them from navigating roads that are broken down and flooding and things like this. And so quite a few people did mention, especially during the Nepal earthquake, they didn't really see a lot of palliative care patients, but they said we weren't looking for them though. Like in our assessments that we did of the needs in the community, they weren't asking about that, and so it didn't come up. And they talked a lot about how unless you look for these people, you won't find them during a natural disaster. The other big thing that came out was these difficult triage decisions. I do feel like it was most notable in Haiti. I feel like a lot of the other disasters, people did get the sense that they were able to manage the number of patients, but in Haiti and specifically, it was talked about that, you know, people were being black tagged and put in behind a shed or things like that. There just wasn't enough capacity, and I think the healthcare providers really felt that it's not realistic in that first couple of days to expect what we would call true palliative care to happen. That's just not realistic, but they did feel like there was things that could be done. Those patients should still have access to pain control, and they should still have someone to sit with them, whether that's a volunteer or someone. So there was some strategies there that they suggested, and that the role of palliative care and the ability to provide it really increases over time. So the first couple of days, it may only be here, but there needs to be specific planning that's done ahead of time and kits prepared for palliative care so that you can ramp that up very quickly. And within the first week, people felt that you should be able to provide pretty comprehensive care. Those are sort of the main findings. Just some key messages to pull out of that. People really felt like we need to be realistic about what we can do, and that during that first few days, it may be limited, but we need to plan for those simple things that could help. That individuals with palliative care needs are hidden, and we need to seek them out if we're going to care for them. that incorporating palliative care into disaster planning is critical, because if we don't plan for it, it's not going to happen, was the message I got. And that, yeah, it just needs to be part of the planning. And people talked about protocols for disasters, including psychosocial care and palliative care, and having like a kit, sort of like an emergency kit you'd have for other responses, that there needs to be a palliative care kit as well. And that's